Good evening, everyone, and welcome to our Making a Difference for Mom, Advancements in Gynecological Cancers webinar. This session is presented by the Princess Margaret Cancer Foundation in support of the Princess Margaret Cancer Center and the 19th Annual Weekend to Conquer Cancer. My name is David Gilchrist, and I will be your host for this evening. I am the manager of the Weekend to Conquer Cancer virtual event, which is taking place the weekend of September 10th through 12th. This year, participants can walk or run any distance virtually in their own community, anywhere in the world, all while supporting vital funds from over 50 areas of cancer research here at the Princess Margaret Cancer Center. Registration is completely free and there are no fundraising minimums. All of our doctors and speakers presenting today are participants of the weekend event. Please join us in supporting their work and philanthropy by visiting www.weekendtoconquercancer.ca. Now, before we begin, some general housekeeping notes. For each of you in attendance, you may ask a question at any time during tonight's webinar using the Q&A feature. If you have a question, please click on the Q&A button at the bottom of your screen and type in your question. Once submitted, the panelists will be able to view your questions and will answer them during the formal Q&A portion of tonight's webinar. Now, with this past Sunday being Mother's Day, in recognition of all women and mothers, we are happy to share with you some exciting advancements that have been made through the BioDiva and Venus clinical trials, as well as other gynecological breakthroughs. These trials involve analyzing gynecologic cancer patients' tumors with the ultimate goal of creating more personalized and precise treatments. Now, before we dive into those improvements, I'd like to introduce all of you to Mark and Sydney Waldman. Mark Waldman is the current Executive Director of the Canadian Jewish Public Affairs Committee, as well as founder and former Deputy Chair. Mark is very active in raising funds and awareness for ovarian cancer and related familial BRCA mutations. Of course, he is also a longtime supporter of the Princess Margaret and is participating in this year's Weekend to Conquer Cancer as captain of Team Ilana's Voice. In fact, I noticed just yesterday that Mark's team has an ambitious goal of raising $150,000 this year. This, of course, would be tremendous and would have a huge impact for future cancer research. Sydney, Mark's daughter and weekend supporter, will also share her thoughts regarding the loss of her mother, Ilana, who succumbed to stage 3C ovarian cancer back in 2013. Now, without further ado, Mark and Sydney, over to you.
Thank you, David, for the opportunity to speak tonight, and thanks to all of you for joining us. As you heard, I lost my wife, Ilana, to ovarian cancer on June 4th, 2013, after a long and courageous battle. She was diagnosed in 2005 at the age of 32. She had the BRCA mutation and knew she had an 87% chance of getting breast cancer and a 50% chance of getting ovarian cancer. However, receiving a diagnosis of ovarian cancer at such a young age was so rare, and she was being monitored. Well, at least her breasts were being monitored. But unfortunately, ovarian cancer is much more difficult to detect. We learned very quickly why it is called the disease that whispers. I now want to introduce you to Ilana through a video we created posthumously from the commercials and videos she did while she was alive.
People often don't want to talk about people once they've died. They want to talk about the survivorship stories. They want to talk about the success. They want to celebrate. They want to be happy. They want to enjoy life and have a smile, and they don't want to be reminded of the things that they can't control. And ovarian cancer, because it is so difficult to treat and so difficult to diagnose, so often leads to death, and people don't want to talk about that. My name is Ilana. I was diagnosed with ovarian cancer on August 19th, 2005. I was 32 years old. diagnosed with ovarian cancer, you have an incomparable risk of dying compared to breast cancer. Although the numbers for breast cancer are 1 in 7 and the numbers for ovarian cancer are 1 in 70, the absolute number of deaths in Canada are the same amount. Pap smears do not detect ovarian cancer. Family doctors do not know enough about the symptoms of ovarian cancer. There's nothing that screams out, oh my goodness, this might be ovarian cancer. That's why it's called the cancer that whispers. It is so highly treatable. And if we just get the word out, and if we get the knowledge out there, and we get the dollars behind the doctors and the scientists who are doing the research, we can flip it. And you know, that 90% cure rate in stage 1 can apply to 90% of the people instead of to 10% of the people. And if we can get an early diagnostic tool, if we can get something that's similar to the Pap smear and what that has done for cervical cancer, we're helping people live, we're helping people survive, and more than survive, we're helping people thrive. And I have been very angry and I have been very scared. And in the midst of all of these emotions, the things that I think about are very little moments, intangible times. The Hollywood moments and the drama, it happens and it matters. But it's not what I'm going to take with me. The more knowledge that's out there, the more care and compassion that is raised, the more money that can be raised for this cause, the more we're helping women who potentially are facing this disease, and we're helping the people in their lives not have to go through this.
So I consider myself exceptionally lucky to have been married to such an incredible woman. While she fought the disease for close to 8 of the 11 years we were married, things were not all bad. We had many wonderful moments together, and the battle with cancer actually enriched our lives in some ways. Now, to properly prepare for tonight, I pored over Alana's blog postings on Shadow Lane. I even reread special notes she left for our daughter to be read by her at a time when she was old enough to appreciate them. And I believe that while Alana had a very successful career in family law, it was her role as a patient advocate that may have turned out to be her true calling. It allowed her to touch thousands of people and to raise awareness for this terrible disease. Alana was shocked when she discovered the enormous disparity between the amount of money channeled into breast cancer research versus research funds raised for ovarian cancer. I'm proud of the fact that through her formidable efforts at raising awareness through her fashion event and her foundation, Alana was one of the largest sources of funding for the research into ovarian cancer at Princess Margaret Cancer Centre. And it's very gratifying to see the advancements that have been made, knowing that Alana was able to play a small part. As a result of her advocacy efforts, the introduction of IP, or intraperitoneal chemo, back in 2006, it was probably the most significant discovery within the last 10 years at the time, according to her doctor. She was the first patient to get approval for this protocol, which is now standard frontline treatment. Thanks to Dr. Oza, she participated in many clinical trials, including PARP inhibitors and Avastin. We had relationships with several of the top cancer research institutions in the US. What was clear was that Princess Margaret was on the same page and offering the same trials. We quickly understood why it is considered amongst the top research institutions in the world. And thanks to many clinical trials, we had hope. And as those of you who have experienced the cancer journey know, that without hope, there's nothing. I know that these cutting-edge drugs and treatments kept Alana alive much longer than anyone expected. Alana's family and close friends have committed to raise money for critical research for ovarian cancer at Princess Margaret. We established a fund and have raised over $975,000 to date. The main vehicle we use to do this is through events that allow us to engage in peer-to-peer fundraising. First, it was the Dance to Conquer Cancer, then the Journey to Conquer Cancer, and now the Weekend to Conquer Cancer. Alana would want everyone to continue raising awareness about this disease. She wanted to not be afraid of cancer, or she wanted people not to be afraid of cancer. It need not overtake your life. To quote her, "I am not cancer and it doesn't define me. It is definitely a big part of my life, but it is not in my top 5 words if asked to describe myself." That's what I want people to see and understand. We are just people who want to be treated as people, not as a disease. Alana would want us all to advocate for more clinical trials. She once spoke at a symposium for clinical trials with industry professionals to provide a patient perspective. Here's what she had to say. "You can't go through the journey without hope. Despair is a bad thing. The ability to take pills and go on with the day-to-day life is huge. Hope helps improve outcomes. In the end, clinical trials helped give her many extra years of quality time and lots of memories." I know some people on this call have never done fundraising before. It can be intimidating and awkward. I was one of those people, but I learned from experience that it is one of the most rewarding activities, and cancers can make you feel powerless. Raising much needed dollars for research is a great way to fight whatever cancer you're dealing with. I discovered that most people want to help, but don't always know the best way to do so. So a great way to answer your friends when they ask, "What can I do to help?" Join or donate to our gynecological cancer fundraising team for the Weekend to Conquer Cancer and help us beat this disease. How can they say no? I can tell you that there's a group participating in the event raising funds for cancers that aren't as common, and they have been consistently raising over $500,000 each year. How, you may ask? Because of a few dedicated volunteers who recruit people directly within the cancer clinic. Given the number of people on this call tonight, if we each reach out to people we know, we can grow this group and raise a lot of money for this important cause. If anyone wants to chat further, I'm happy to do so and provide coaching on marketing and fundraising strategy. My secret weapon, as you'll see, is my daughter, Sydney, who you'll hear from shortly. Now, let me end by sharing with you a story I found from Alana's blog that epitomizes her outlook. So listen to what she wrote. "The other day, I was in the hospital getting my weekly blood tests to ensure my levels were all right to receive chemo. I was leaving the blood lab. A man who was there with his mother leaned over to a woman there with her father. They did not know each other, and the parents were both in the lab having their blood drawn. Without any attempt to lower his voice in the room full of cancer patients, he said to her, 'This place is so depressing.' I didn't even stop to think. I just turned around, looked him straight in the eye, and said, 'Or uplifting, depending on your perspective.' The conversation continued with him telling me he had been through these hospital experiences with his mother and how difficult it was. I told him he needed to look at the positive that occurred at this place. Then he asked me whether I had been poked and prodded and made to feel essentially like a pincushion. He clearly did not think I was a patient. So I told him, yes, every week for over 7 years, they have poked at me, and look at me now. The woman he was chatting with started to applaud, and I just walked out with a huge smile on my face. Yes, I do get into bad moods. I wouldn't be normal if I was always happy. I do question why my family and I have been burdened with this illness and everything that is attendant with it. However, for the most part, I really do see the positive that has been done. I look at the hospital and marvel at the advancements that have been made and the people whose lives have been saved. I think about the fact that I was not supposed to live beyond 5 years, and it has already been more than 7. I focus on the beauty that I've been able to have in my life and cherish those times. I know that there will continue to be challenges in my path, and there will be more difficult times ahead. But I also know that there will be the opportunity to create some beautiful memories, and there will be magic to celebrate. I choose to focus on the magic. Well, we certainly had a lot of magic together. When I think about what Alana would want us to advocate for going forward, I imagine her being really excited about the noise everyone on this call can make in order to ensure that ovarian cancer is no longer the disease that whispers. And I know that she'd be really excited imagining all the advancements that are going to be made through the research efforts of talented doctors at Princess Margaret Cancer Centre, through the funds we will raise together, all made possible because of your commitment to this critical cause. So let me end by saying thank you for your support and making possible the continuation of Alana's mission. I will now turn things over to my daughter, Sydney.
Hi everyone, my name is Sydney Waldman and I'm 17 years old, almost 18, heading to Queen's University in the fall. As you heard from my father, my mother, Alana Waldman, passed away from ovarian cancer. I was only 9 years old when that happened. Thanks to the clinical trials at the Princess Margaret Cancer Centre, she was able to live a lot longer than the doctors had expected. It's because of their wonderful work that I was able to spend more time with my mother. By participating in events like Dance to Conquer Cancer and the Weekend to Conquer Cancer, I've been able to carry on my mother's work and help others by raising money for ovarian cancer research. My friends and I have been participating in these events for almost 9 years now, and it's been a great outlet for my friends to give back and do something positive to honor my mother, who they were very close with. I was so young when she passed away that sometimes I find it difficult to remember certain memories with her. One memory that has stuck with me is a few weeks before she passed, my uncle gave me an activity book to fill out with my mother. Being only 9 years old, I didn't want to fill the book because I didn't think it was important, and I had other priorities. You know, being the busy fourth grader I was. Years later, and it has become one of my biggest regrets. I wish I had filled out the book and gotten a final form of closure with her before she passed. At that age, I didn't really understand how sick she was or the concept of death. Every day when I came home from school, she was still in her bed, awake. And I told myself there would always be tomorrow, until there wasn't. Going through certain milestones in life without my mother has been extremely difficult, and as I grow older, the loss grows to be more painful. It truly does take a village to raise a child, and while I'm extremely grateful for those who have stepped in and tried to be a mother figure for me, it will never be the same. By participating in events like the Weekend to Conquer Cancer, we can ensure that other kids won't have to go through what I had to go through. I want to conclude by thanking everyone for joining us tonight, and I hope that you'll consider participating in the Weekend to Conquer Cancer and encourage your friends and family to do the same, especially kids. We all have a role to play in defeating cancer.
Thank you so much, Sydney and Mark, for your inspiring story. At this point in time, I'd like to introduce everyone to 3 outstanding panelists who work here at the Princess Margaret that will be speaking to the advancements that have recently been made as a result of passionate supporters like Ilana, Mark, Sydney, and many of you in attendance. Dr. Amit Oza will be sharing a video message with us and is the head of the Division of Medical Oncology and Hematology and Medical Director of the Cancer Clinical Research Unit at Princess Margaret Cancer Centre. Dr. Oza has been principal investigator and co-investigator in more than 100 phase 1, 2, and 3 trials for gynecological cancer and advanced colorectal malignancies. Under his direction, the gynecology group is one of the largest ovarian cancer clinical trials groups, consistently accruing greater than 30% of all patients seen onto clinical trials at the cancer center. Under his direction, the group has participated or led seminal studies in gynecologic cancers that have led to the approval or use of targeted agents such as PARP inhibitors and anti-angiogenic agents internationally. Dr. Stéphanie Lheureux is joining us today as well and is a clinician investigator, medical oncologist, site lead of gynecology oncology at Princess Margaret Cancer Centre. She is an assistant professor, faculty of medicine, and associate member, graduate faculty of the Institute of Medical Science at the University of Toronto. Her clinical and academic interests are focused in gynecologic cancers and early drug development, with an emphasis on translational research, and have garnered 2 ASCO Merit Awards. In the last 5 years, she has over 60 peer-reviewed publications in widely cited journals. She is principal investigator or co-principal investigator in several large-scale peer-reviewed funding opportunities, including the Canadian Cancer Society Research Institute, Conquer Cancer Foundation, American Society for Clinical Oncology, and the Ontario Institute for Cancer Research that converge preclinical and clinical areas of interest and benefit from her unique expertise in each of these domains. And lastly, Valerie Bowering will also be joining us and has worked at Princess Margaret Cancer Center as a clinical research nurse for 12 years and is a research manager with the Drug Development Phase 2 program. Amit, Stephanie, and Valerie, over to you.
Good afternoon and welcome to this presentation related to the Weekend to Conquer Cancer, and specifically with a focus on gynecologic cancers and ovarian cancer. I'd like to start off by first thanking David Gilchrist for actually putting this presentation and seminar together, as well as Mark Waldman for actually participating and being such a strong advocate for our gynecologic cancer program and ovarian cancer program. And as you will hear this afternoon, we're going to sort of take you through a little bit about what we're doing in terms of ovarian cancer research and gynecologic cancer research to try and improve outcomes in these difficult malignancies. But first of all, I'd like to thank you all for participating and also apologize for not being here in person to be with you right now. I will try and participate in this, but unavoidable circumstances have made it a bit challenging for me to be here in person at the start of this meeting. I thought that I would just give you a quick overview in terms of gynecologic cancers, and I think that this is something that many of you are probably familiar with. Gynecologic cancers are challenging cancers that we deal with. They are cancers that may sometimes be associated with presentation at an advanced stage, and outcomes have been challenging. But I think that we're actually making very, very good progress in these cancers. Many of these cancers are genetically driven, and we are beginning to understand this, particularly related to ovarian cancer. But there's also changes that we're identifying at the tumor-specific level that we can actually learn from and understand and use this information in terms of really leveraging this in terms of identifying vulnerabilities in the cancer. And this is beginning to change the shape of our treatments. It's also important to recognize that these changes change over time and change with our treatments that we're giving. And this microenvironment in the tumor is constantly dynamic, and we need to sort of understand it with respect to how we approach treatment going forward. And at the end of the day, what we're really trying to do is to understand the biology of cancer and trying to see if we can actually use this to improve the precision of the therapy. The cancers themselves are very much like our approach to treatment is really like an iceberg. There's been a lot of progress that is seen at the tip of the iceberg, and we're making sort of really good strides in terms of many of the novel treatments such as PARP inhibitors, bevacizumab, and building on a base foundation of platinum-based chemotherapy. But there's a lot of work that's actually going on behind the surface that is sometimes invisible, but which will in fact contribute to improving the outcome of treatment very significantly. This is one of my sort of favorite slides to show at meetings, and this basically is the dramatic improvement in outcome that can perhaps be seen with understanding the biology, leveraging that into treatment with PARP inhibitors in women who have genetic susceptibility to ovarian cancer and have BRCA mutations. And this really shows that over the course of the last few years, we have demonstrated that improved outcomes are really possible with treatment that can be administered for an additional maintenance period of a couple of years beyond chemotherapy. And with PARP inhibitors, women who participated on maintenance treatment with PARP inhibitors had a profound improvement in their outcome compared to patients who did not receive PARP inhibitors. And this has led to a new standard of care being defined worldwide in terms of ovarian cancer, which is really exciting to see. But we still have a long way to go. And as I mentioned, that cancer changes over time, and we're beginning to sort of really learn and understand that the cancer that is often initially present at the time of diagnosis, which has many different types of cells within it, will potentially change and evolve over time with new subclones of cancer appearing over time. And these may have a different responsiveness to treatment. And that's why our treatment approaches need to be constantly adapted to understand what's happening in terms of the biology in the patient. And what we're really trying to do at Princess Margaret is to really take the entire trajectory that patients go through in terms of their treatment, trying to improve the outcome of treatments at every stage, but also take into account the biology and how we sort of incorporate that information about changing biology, whether it's because of the treatments that we're giving, or whether it's because of the chemotherapy, or whether it's because of the patient and her tumor microenvironment, or whether it's because of the microbiome, i.e. the type of microbiome and the biology which may be impacted in terms of the diet and nutrition in the patient. And how does that in fact affect the way our treatments work? At the end of the day, what we really want to lead to is to have important outcomes, which from a patient's perspective are to try and improve treatment so that patients may be able to live better and live longer, and make sure that we actually try and do this for as many women as possible with gynecologic cancers. Our approach is also very much to try and make sure that everybody is able to sort of have access to improved care. And I love this quote, which is, "The rising tide lifts all boats." And I think our job is to really try and make sure that everyone has a boat, and that we actually allow the tide to rise and raise all of the boats and raise the treatment for all women who have gynecologic cancers. Last week was World Ovarian Cancer Day, and I think that we have come a long way in terms of treatment for ovarian cancer, but we still have a very long way to go in the future. And once again, I'd like to turn the seminar over to Stéphanie Lheureux and Valerie Bowring, who will take you through some of the new and exciting developments that are taking place at Princess Margaret. And thank you very much for participating and for your support.
Thank you, everyone, for being there with us tonight. And a deep thank you to you, Sydney and Mark, for these inspired quotes and words that really define our mission and really inspire us to do better for every woman, and to look at the positive and how we can help each woman and improve treatment for cancer. So thank you, everyone. And with Val tonight, we will definitely try to see how we can raise the bar together and see how we can improve treatment and outcome for women with gynae cancer. So we are here, and it's as Dr. Oza just mentioned, last week was the Ovarian Cancer Day, but it was also the Mother's Day. But actually, we are all here because we have a mother, a sister, a wife, a daughter, a friend, every woman that we know in life that have a specific space and is really somebody that we want to help and support. And it's actually why we are all here tonight, is really to try to see how we can support and look together in the same direction to look at the rise. So we want to spend this time together to see what is the positive and what is the improvement, and how we can work together to continue this mission. So first, we want to say a little words about what is gynecological cancer. And gynecological cancer, it's a big box, but have different type. And we talk about the ovarian, but now it's also important to consider the fallopian tube, because there's some new research that maybe the initial cancer from the ovary start in the fallopian tube. So there's a lot of research currently to see how ovarian cancer start, and it seems that the fallopian tube can have the initial lesion and then can have small lesion for a few years before unfortunately being disseminated. So there's a lot of research on that. Gynecological cancer is, as we say, like ovarian cancer is a deadly type of cancer. Is approximately in Canada, 8 women are diagnosed with ovarian cancer, as in unfortunately is the most serious women's cancer, and be the 5th most common cancer for women. But we also have, unfortunately, the uterus cancer that is on the rise as well. There's increased diagnosis of uterus cancer worldwide. And that is something that our group also focus to try to see how we can improve the detection and the treatment of uterus cancer. And when we look at the gynecological cancer, there's also the cervix, the vagina, and the vulva. That is also a component of gynecological cancer. And as Elena mentioned in a very meaningful video, is that gynecological cancer is not something that we speak as much as the other cancer, but it's something that definitely we need to increase awareness and see how we can improve outcome. And the problem is actually most of the gynecological cancer, if it's ovarian, uterus, or cervix, is that the symptoms are very not specific for gynecological cancer. It could be, as here mentioned, it could be the ABCD of gynecological cancer: A for abdominal pain, B for bleeding, C for change in your body, and D for discharge, and something different. But as you can see, it's very not specific. So unfortunately, it's why we don't have any screening tool for gynecological cancer. Unfortunately, we don't have a good test as the PSA for prostate that we can use to actually act early. There is no screening tool, and the symptoms are very not specific. So it's why it gives really a challenge to actually detect early. So it's why we, our program, try to have some specific study and trial looking at how we can eventually screen and act early on gynecological cancer. And here's a summary focusing here on ovarian cancer. Is unfortunately the symptoms are very ambiguous, and that actually didn't trigger necessarily an investigation because it could be very not specific and difficult to diagnose. And when we look at the diagnosis currently, it's still very basic for gynecological cancer. If we look, we have a blood test, which we can do with a CA-125. But as you can see here, the sensitivity and the specificity is quite low. The CA-125 can be done to actually see these gynecological cancer, but it's very not sensitive and specific. And all the trials to see if we can use CA-125 to detect gynecological cancer have failed. So that is not sufficiently specific and sensitive. Then you have the imaging, and we can use the ultrasound. But again, as you can see, the specificity and sensitivity is not high. And it's why we're trying in our team as well to have some more specific tool that we can use to follow and monitor gynecological cancer. For now, the diagnosis remain to be on the tumor tissue biopsy, which is quite invasive because it requires tissue biopsy, but is very specific and sensitive. So it's one area that is currently under investigation to try to see if we can develop more specific blood tests that is specific for each gynae cancer and new tool for imaging. And what do we use currently for the treatment of gynae cancer? We have different tools that we can use. We can use hormone treatment, surgery, we can use chemotherapy. In specific case, we have immune therapy and radiation. But definitely here, we're trying to really improve the personalized therapy and really be specific to each woman. And for that, if we want to be specific for each woman, we really need to develop specific biomarker to indicate which patient will respond to what treatment. And we really need to go deeper in how we characterize the cancer to be very specific. And how can we actually change the treatment? And as Elena testimony said, we change cancer treatment by doing clinical trial. And all our new treatment strategy in gynae cancer is based on the result of clinical trial. And clinical trial can be performed at different time of the disease. And if we want to improve the treatment for patients, we need to show that this treatment is safe and active. So it's why all our treatment is based on the result of clinical trial. And if we take an example here of the ovarian cancer, before ovarian cancer were treated with surgery and chemotherapy and nothing. And as Dr. Oza mentioned, now we have this kind of maintenance strategy with the PARP inhibitor treatment for some patients. We have some new treatment with the bevacizumab. And now we develop additional new treatment at the time of relapse and clinical trial. And we have new treatment because of the clinical trial showing benefit. But it's something that we need to learn deeper and to do more investigation about how the tumor is evolving, because more we treat patients, more the tumor develop new system of resistance. And maybe the tumor was looking like that at the beginning, but with treatment evolution, this changing. And it's what we're currently doing in our program, to try to learn with the patient as well on treatment to see how best to target this new change. So in our program, it's really focusing on women's cancer and gynecological cancer. So we are home of the largest early phase clinical trial. We enroll more than 150 women every year into clinical trial. And our site at Princess Margaret have several trial options, but we also work in the Canadian network, and we participate in different trials in the Canadian network. And we also work with the National Cancer Institute collaboration and also the International Gynecological Cancer Intergroup with other countries to make sure that we offer the different trial that is currently offered to women. And our team actually has led to the approval of different treatment, including the anti-angiogenic, the PARP inhibitor, and also the immune therapy in specific subgroup. Immune therapy is still a lot that we need to learn of. Immune therapy has shown significant benefit in lung cancer, in melanoma, or in kidney cancer. In endometrial cancer, there's some benefit of the immune therapy. For ovarian cancer, there's still a lot that we need to learn because immune therapy alone seems to be not sufficient, and we need to learn why. And in cervical cancer, immune therapy have shown some benefit for a subgroup of patients, and there's a lot of new trial coming up to see how we can increase the response to immune therapy in gynae cancer. So our group is really trying to focus on the discovery and innovative therapy, and really try to promote the academic research and not only do research sponsored by a company. And the challenge that we have in gynecological cancer is that there is common type of gynecological cancer, but there is also some uncommon and rare type of gynecological cancer. So initially we discussed a different type of gynecological cancer, but when we go deep diving, actually these ovarian cancer is a big box with different type of ovarian cancer. The same for cervix. Cervix is a big box, but have different type of cervical cancer. So we need to go a little bit more deeper and to treat appropriately our patients. So that is just an example. Ovarian cancer, it's not one size fit all. So when we talk ovarian cancer, and here is just the epithelial ovarian cancer, you have 5 different types of ovarian cancer, which we call high-grade serous, low-grade serous, clear cell, endometrioid, and mucinous. When the pathologists look at the tumor biopsies that we took for the diagnosis, we see that they are different. They look different. And when actually we go deeper and when we do the sequencing of the tumor, and we can do sequencing at different levels. We can do sequencing at the DNA, we can do sequencing at the RNA, and we can also look at the protein. And we can see that inside this specific category, there is difference. So for high-grade serous ovarian cancer patients, some patients will have the BRCA mutation, some patients will not have the BRCA mutation, but behave like BRCA, and some patients will not have that. So you begin to see that even inside this big category, there is different type of cancer, and that is biologically very different. So they would behave different and respond different to treatment. So for example, here, the high-grade serous ovarian cancer initially are sensitive to the platinum-based chemotherapy, but the low-grade actually are relatively resistant to it. And then when we look deeper at the new treatment, the PARP inhibitor or the MMR deficiency, the response will be different because biologically they are different. And it's the same for endometrial cancer. We talk about endometrial cancer, but again, there is different type of endometrial cancer. And you have different type based on the pathology on the microscope when you look at the tumor. But again, when we look at the biology, they have different expression. And because they have different expression, they will behave differently. So it's why we need to go a little bit more deeper on how we characterize the tumor to offer the best option for the patient. So it's really our focus, and here is our medical oncology team at Princess Margaret. So you heard about Dr. Oza, myself, and then after this, Dr. Danny and Dr. Grant who just joined our team. Dr. Danny is really focused on the hypoxia and the angiogenesis, and Dr. Grant has been recently recruiting, focusing on all the intelligence artificial as well. So our strength is really clinical, so we have a big portfolio of clinical trial. We manage the different type of gynecological cancer, including the rare type of gynecological cancer. We also have multidisciplinary approach. So we work with our colleagues to ensure that we offer surgery and radiation when appropriate. And definitely research is a big part of our practice with offering clinical trial. And also when we have all the biopsy, the tumor, the blood, it's very important to go back to the lab and learn from it. So we really have a lot of translational study when we go back to the lab and try to learn from it. Currently, as a snapshot, we work with 40 trials from industry, also from academic. We also have a lot of trainees because we are experts in gynecological cancer. We often welcome some clinical research fellow that came to work with us for 2 or 3 years to learn about the trial, the research, and how to run this kind of program. So one of the example of actually why this is important to learn from each patient. That is just a pure example that we can look at the extreme. For example, it's one of our patients that, as you can see here, she initially had the diagnosis of high-grade serous ovarian cancer, had surgery and then chemotherapy, and then was on surveillance. But unfortunately, recur, was treated again with chemotherapy and then observation, because at that time there were no maintenance treatment. And then unfortunately, recur, have again chemotherapy, no maintenance because it was not available at that time. And then at the fourth relapse, she was enrolled in a clinical trial and got a PARP inhibitor treatment. Really have a long and prolonged benefit to the PARP inhibitor treatment, but unfortunately relapsed and then were returned again with another medication. And each time point we were able to collect tissue and blood to try to see what actually lead to the resistance or the response to the treatment. So what is interesting, as you can see here, when we look at the tumor, so we took the biopsy at the initial treatment and we put the profiling. And we look at the tumor when she was progressing on the PARP inhibitor treatment. The tumor looks very different. It's not the same. It's still called, when we look at the microscope, it's still ovarian cancer, but biologically it's very different. And when we look more at the expression of the gene, you can see here that at the beginning, she did not express BRCA, but the tumor, while she was on treatment, recover and can express the BRCA. And another gene, which is called cyclin E, which is on the cell cycle, and it's why we begin to develop a lot of cell cycle treatment. The cell cycle was actually not expressed, so she had a normal cell cycle. But when she progressed, the cell cycle was completely random and really progressing fast. And you can see that the treatment should be different and should try to target what we have seen in the change of the tumor. And another aspect that we also want to learn, and that is an example from endometrial cancer, is that endometrial cancer, we begin to know that there's a subgroup of population that are what we call MSI high, and that can be also related to the Lynch syndrome. And again, endometrial cancer is a big box, but with different type. And we don't know actually, who will respond really to the immune and not. And now we know that the patient with MSI high will respond to the immune therapy, but the one who are not MSI high, they probably need a combination. So now, and we have done this trial showing that when you combine an immune therapy with an anti-angiogenic, you have a signal of activity. And this is active also in aggressive form of endometrial cancer, the one who have progressed prior to prior immune therapy or the carcinosarcoma. So definitely the immune environment is important, and we have shown that in endometrial cancer. And by doing a biopsy at baseline of the endometrial cancer, we were able actually to see that, again, when we do the immune profiling, it's a big box, but when we look deeper, there's different type of immune cells. So you have different type of immune cells. So it's the first time that we were able actually to characterize the different type of immune cell inside this biopsy and try to identify what is the population of immune cell that is required at the baseline before starting treatment to actually respond or not respond to the treatment. So definitely all this research actually is usually conducted as part of clinical trial, and that is just a snapshot of a trial that we have been involved. And all this trial actually then are published and are available through the PubMed website. And And that is important because it's all this study need to be published to actually advance science. So really our focus, really, as you can see, is really focusing on the resistance and how actually we should overcome the resistance to the treatment. Because unfortunately, most of our patients with gynecological cancer will recur. And for example, in ovarian cancer in Canada, 5 women die each day because of the resistance to the treatment. And as we discussed about the PARP inhibitor treatment, we have conducted this specific clinical trial where patients have been treated on PARP inhibitor treatment and they unfortunately progress. And at that time of progression, we have done a biopsy again, and we compare this biopsy at the time of progression compared to the initial tissue to see how changed and what has the mechanism of resistance. And what we have seen is that the mechanism of resistance is different for each patient. So this trial actually was trying to see if you progress on PARP, can you be rechallenged with a PARP and combined to an anti-angiogenic? Yes, some patients have benefit, but not all. And the benefit depend on the mechanism of resistance identified at the time of PARP resistance. And this mechanism of resistance is not necessarily dependent on the platinum sensitive resistance. So that is all the progress that we're currently trying to make. And the next step that our team now is doing is, can we identify this mechanism of resistance, not only on the tumor, but on the blood? And can we do that in a timely fashion to guide the treatment based on the mechanism of resistance that we have identified in each patient? So that is kind of a big task because that will require a lot of people to be able to make that. And as we discussed, we want to treat patient, the woman, the people, not necessarily the disease. So we need to take into consideration all. So we need to look at the patient as a patient, and also took into consideration all the aspects, the immune, the genomic, also the pathology, the tissue, the bioinformatics. So it's why we work actually with a lot of scientists to take that all into consideration and to integrate. And as we mentioned, we really think that the only way to move forward is to learn from each patient, and really our patient, our drive and our motivation. And I wanted to highlight this specific platform, which we called BioDiva, which was, a big program for us. And it was supported by patients. So, and that is really trying to see if we can learn from each patient at different time. So for patients, when they are diagnosed with ovarian cancer, we want to collect the tissue at each time of progression to try to follow the evolution of the disease. We want to collect the blood as well at each time to see if we can actually detect on the blood and not necessarily have the tissue every time. We want to do the same, not only for ovarian cancer, but also for all gynecological cancers. So we have built the same program with any gynecological cancer, and it's the same principle. We will collect tissue and blood at a different time point to learn from each patient and the disease evolution. We currently, as part of BioDiva, we have now more than 250 patients. As part of this Venus, which is all gynecological cancer, we have 300 patients with different blood and tissue already collected that we need to analyze. And as I said, we really want to move from the biopsy to the blood. The idea is actually when you have tumor, the tumor also sheds some cell in the bloodstream. And the idea is, can we detect this tumor cell in the bloodstream to really guide the treatment at the time of progression? So really the objective is really, if we want to be specific and be targeting for the patient, we need to have specific biomarker and marker of response to resistance. So these two trials, which is BioDiva and Venus, are really biomarker discovery, integrated all the aspects of the cancer, not only one aspect of the genomic, but epigenomic, the immune, and the genomic. So to really have this kind of trial happening, it really takes a village and a lot of people, and that Val can definitely speak more about what really we need to make this happen.
Thanks, Dr. Lheureux. So thank you everybody for joining this evening and for inviting us to speak with you and highlight some of our program. So as Dr. Lheureux has said, it does take a village. All of that blood collection, all of the data collection, all of the tissue processing, it takes a lot of people behind the scenes to look after that. It also takes a lot of people behind the scenes to look after the patients in the front line as well. So we've got different physicians, clinical trial nurses, pharmacy, medical imaging, clinical research coordinators, statisticians, and many different specialties that are required to be able to make all of this run. It also takes a village within the lab. So it's not just taking the blood sample and then getting the result. So we have to have the blood sample, we have to have it spun and processed properly. It then goes in for analysis, and then somebody has to read that analysis and break it down for people like me who need to understand it. So it does take a village behind the scenes that people don't always see. So our mission really is from the lab to the patient, and then back from the patient to the lab to be able to understand the different diseases, to be able to really impact the clinical care. This is something that we have strived to do over the years. And I think that with BioDiva and with Venus, we have been able to inch forward. And as we continue to move forward, these advances will continue to be able to impact the clinical practice that we have. So this is the impact. You know, we want to impact the care now and also in the future. Are there ways that we can detect sooner disease? Are there ways that we can detect disease from coming back? Is there blood work that can be done? So as Elena said, there isn't a testing that can be done to diagnose, but is there something that we can do other than a biopsy? Everything is invasive right now. Is there something that we can do? So can we predict it? Can we act on it? Can we change treatment based off of what we're learning from the lab and then making those changes with the patient? So it really is a partnership with everybody, with our patients, with all of the different departments within the group, with the foundation. It really is a partnership, and it does take a village. So as Dr. Lheureux had said, you know, we look at the tissue, we look at the blood, we look at the science, and all of that is extremely important. And I hope that you've learned that this evening, but we also have to really look at the patient and the family. And I think Mark and Sydney really did highlight that this evening, that we have to focus on the patient and what it is that they're wanting as well. And how do we learn from each and every patient? So I did have the privilege of caring for Alana on a few different clinical trials. And as you will have seen in her video this evening and listening to Mark and Sydney, she knew what she wanted and she knew what she didn't want. She definitely impacted me and my clinical practice. One of the things that I learned from Alana is, you know, about the different side effects of the treatment. And it actually changed how I teach my patients about chemotherapy, about the side effects of the different clinical trials. So it's not as much as, you know, we talk about the science and we talk about, you know, learning from each patient. There's other things that we can learn from each patient as well. And I think that's something that our team does really well. We listen to our patients. We understand what it is that they're telling us and try to make changes. And for Alana, she told Dr. Oza and I that we needed to do better. And I think that's what we continue to strive to do. We've also had other patients that have spoken with us about different aspects of their care. And, you know, one of the things that one of our patients had spoken about was, you know, being able to have continuum of care. So patients that come here, they come for clinical trials, or, you know, they're an inpatient, and then there seemed to be a bit of a gap when they come back and they, you know, they go home, their home care, all of those types of things. So this was something that one of our patients had suggested to us, and with their support and with the drug development program with Maggie Braz and the Braz family, we've been able to create this clinical coordination program. So we have a physician assistant and we have a clinical coordinator that is helping us to be able to make sure that there's streamlined care between patients, whether they're on a clinical trial and then going to standard of care or back and forth. It's making sure, or if they go to their local community, we're working on how we can make all of those transition points much easier for the patient and their family. think that you've heard this evening that, you know, we want to be leading, we want to lead the innovation, we want to make changes, but we can't do that without people's support. So that's, you know, part of that. We want to listen to each of our patients. We want to listen to their families. What's important to them? You know, is it important for them to climb that ice mountain? Is it important for them to travel? All of those types of things, and then making an impact in everything that we do, the science, the clinical care, and the research. So our patients, they really are our motivation, and hopefully you've heard that this evening. Dr. Lheureux, is there anything else you'd like to add?
I really want to thank you for being there tonight. And as we mentioned, like, it's true, gynecological cancer are challenging to treat, but it's also an opportunity. And looking at the positive side, like, yes, there's change that has been made, and I think altogether we can continue to do this change. I really think that we are getting, you know, some improvement, and it's why altogether I think we can continue. So deeply thank you, and I'm really honored to be with you today.
Thank you, Dr. Oza, Dr. Lheureux, and Valerie Bowering for summarizing the intricacies of gynecologic cancers and providing these detailed updates. Certainly, it's about working with each patient and customizing the way forward for each of them. Clearly, your research and support is continuing to make significant advances for all gynecologic cancers, and we really appreciate everything that you do. So at this point, we welcome all of our attendees one final opportunity to ask any questions you may have for our Princess Margaret speakers. So once again, to do so, simply click on the Q&A button at the bottom of your screen and type in your question. So we have one question here. So this will be for Dr. Lheureux and Valerie Bowering. So has there been any progress in treating low-grade serous ovarian cancer that doesn't respond to chemo?
Yeah, thank you. So yes, there's progress ongoing, because as we discussed, it's true, like, low-grade serous ovarian cancer is not high-grade serous ovarian cancer, despite its ovarian cancer. So we know that they behave differently. And they don't respond the same as high-grade serous ovarian cancer to the chemotherapy. So the question is what and how best to treat this patient with low-grade serous ovarian cancer. These are some recent retrospective studies show that hormone therapy actually in low-grade serous ovarian cancer can be beneficial. But that was retrospective studies. So retrospective study may have a lot of bias because the patient are not followed the same way, and you can have a lot of interaction to see how to interpret the data. So because of the biology, we know they behave differently, that they may not respond as well to chemotherapy. There is now an international study that is running in Canada and in US that looking at patients who are diagnosed with low-grade serous ovarian cancer. They will undergo surgery to try to remove the cancer. And after surgery, some patients will have the standard chemotherapy, or actually some patients will not have chemotherapy anymore and have the hormone treatment. Because it's the question, you know, do we need to treat this patient with chemotherapy or not? We don't know yet. So it's why we need to do that in an objective way. And it's why clinical trials are there. Is really to say, and we will assess the patient all the same way. And we can then, after the trial, answer the question, do we need to or not to do chemotherapy in specific setting as part of the trial?
Okay, great, thank you. A couple more questions have come in here. So have any advancements been made with individuals who have Lynch syndrome? I currently have this mutation, and my mother, who just passed away, did as well. With a 60% lifetime risk of being diagnosed with gynecologic cancers in some cases, and endometrial cancer in particular, I don't find there's enough awareness. I hope to see an increase in this, just as there is with BRCA gene mutations.
And actually, you're right. There is hope as well to increase awareness because before ovarian cancer, we didn't have as much awareness about BRCA. Like a few years ago, BRCA was not as prominent. We didn't know much about, but there were a lot of awareness and a lot of campaign. So now every patient with high-grade ovarian cancer should have a BRCA testing. So now we have significantly improved that. And you're right, Leach syndrome can lead to gynecological cancer and particularly endometrial cancer. And that is a work in progress. It's a work in progress, and now there's some change coming. And it's true, like now for endometrial cancer, when you have a specific type of endometrial cancer, the MMR testing should be offered that we didn't do a few years ago. So now, again, it's try to characterize more the endometrial cancer. And when you have a specific characteristic of this MMR on the tumor, you may be lynched and maybe offer a genetic testing. So that is currently changing. But it's again a work in progress, and definitely agree with you that you need to be more awareness, and there's but that is ongoing, but definitely more work to be done.
Great. I have two more questions. Yep, two more questions. So are there Canadian statistics on the various types of gynecological cancers? Example, vulvar, ovarian, cervix, endometrial, uterine, and survival rates in 2021? So that's a good question.
It's a good question. So there's a Canadian Cancer Society that actually puts statistics on a regular basis. So it's projection because we will not have from 2021, but yes, there's the Cancer Canadian Societies that publish regularly the statistic about the different type of cancer. Yeah.
Yep, certainly. I wondered if you can speak to hysterectomy as a preventative measure for gynae cancer.
Yeah, so that is a good one. And so, for example, we don't do that systematically. For example, if we took the example of ovarian cancer, if a patient, like if a woman is identified as being a carrier of BRCA1 and 2, the question will be to have this prophylactic surgery for the ovarian cancer. For uterus cancer, we don't have this kind of specific prevention measure. So again, it's because we don't necessarily know which patient would benefit from this procedure. And again, doing an hysterectomy seems simple, but it can actually have some potential side effects as well. So we don't want to remove the uterus to every woman if it's not required. And again, like it's something that is very, like we talk about intimacy, like, you know, when we talk about the ovary, the uterus is something very linked to the intimacy. And so it's why, like, if we do this kind of preventive surgery, I think we need to be very specific of selecting the patient and do it at the right time as well. But it's where we go to the problem of screening, because we don't have a screening tool. We don't know when to do it and for who to do it. So it's why if we try to really go more deeper on the biology and try to really identify this precursor lesion and try to see if we can develop specific tests, then maybe if we're able to say, oh, we detect something, so yes, maybe we need to do kind of prophylactic measure. But to propose that to everybody, we may have more harm than benefit. So it's why it's always kind of a balance that we need to be careful of.
Right. Okay. I have two more questions. Do you have any trials currently for borderline ovarian tumors?
Good question. We don't. We don't. The trial that we're having is true, is at the different time of the disease, like we have at the time of the first line and the time of recurrence. But the borderline are not necessarily considered as you know, cancer. That, so it's why there's no specific clinical trial. But it's something that definitely we can have some academic research, but a clinical trial looking at a drug, we currently don't have.
Okay, good to know. And then the last question, a new genetic marker, RAD51KD, is reportedly a precursor to OVC in only 1% of women. Are there Are there other new markers? And can these markers be detected early and lead to a treatment intervention before symptoms are seen?
Yeah, the RAD51. So yes, the RAD51. So there is a RAD51C and D, and actually recently has been published to be also biomarker of response to PARP inhibitor in addition to the BRCA1 and 2 because they behave like BRCA. So because they behave like BRCA, it's not surprising that the fact that you have a RAD51C, you can also be at risk of ovarian cancer as well if you have that genetically in the germline setting. So yes, it's a lot of work currently doing. So yes, now for the genetic testing, we not only do BRCA1 and 2, but now we're doing a panel because we know that there's not only 2 or 3 genes, but now with the knowledge increasing, we have actually now a panel of genes that we do for the germline testing. And it's why also for our profiling, we actually do much more gene than we're doing a really big panel of gene now, because we know that there's much more gene involved now.
Right. Okay. Thank you. Yeah. So in closing, we're extremely grateful to have Mark and Sydney Waldman, Dr. Oza share a video with us, Dr. Lheureux, and Valerie Bowering share their stories, expertise, and latest clinical breakthroughs with us. So on behalf of the Princess Margaret Cancer Foundation, your vision and dedication to help us conquer gynecologic cancers in our lifetime is truly inspirational, and we thank you for your time. So for many of you that have attended or watched this webinar virtually, your support has funded exciting research that is breaking new ground in our understanding of gynecologic cancers. Women at the Princess Margaret across the country and around the world will ultimately benefit from the improved treatments that your generosity has made possible. So again, we encourage all of you to register for free and walk or run at the Weekend to Conquer Cancer this September, and to support our battle directly and donate to Team Ilana's Voice or to any of our panelists participating this year at weekendtoconquercancer.ca. So of course, you can rewatch this session as well as many other informative webinars on our YouTube channel. So thank you all so much for your continued support of the Princess Margaret. We hope that you all remain safe and well. Good night.